The originators envisioned IMERI to create better healthcare and quality of life through disruptive innovation in medical education and research. Groups of researchers have been invited to participate in IMERI and form their own medical science cluster. These research clusters include a wide range of expertise and facilities. Most of the clusters have international collaborations and are part of sustained consortia. Medical education are also increasingly being organized on a problem-based strategy, which requires multidisciplinary collaborations in education that is indispensable in the current era. The medical science are supported by so-called medical research core facilities, which are part of IMERI and are directly accessible by IMERI scientists. General supporting facilities are provided by IMERI for researchers, educators, and all staff from the cluster to meet each other, exchange ideas, and establish networking. IMERI is stimulated to discover novel ways to diagnose, treat, and prevent diseases, bring innovation from the laboratory benches to the clinics and to the marketplace, provide novel technologies to enhance the education of future doctors and other health professionals, building and sustaining Indonesia's educational and research capacities. To produce innovative science, truly new knowledge and intrinsically motivated researchers are needed that are given the opportunity to systematically formulate medical science research strategy. The medical education have determined 3 research strategies to cope with global requirements but still addressing the local needs. IMERI is open for all talented researchers and educators to achieve experience, excellence, and great innovation. Indonesian Medical Education and Research Institute provides an academic atmosphere that has a flexible platform for a convergence in research.
Terima kasih. Demikian tayangan kami dari Indonesian Medical Education Research Institute, IMERI FKUI. Tadi sudah diperlihatkan mengenai berbagai macam fasilitas yang ada pada kami. Kami berharap para peneliti, para saintis bisa turut bersama-sama kita membangun riset-riset kedokteran di IMERI untuk pembangunan kesehatan di Indonesia. Saya tunggu kehadiran Anda semua. Terima kasih.
IMERI, nurturing Indonesia towards health and prosperity.
Good afternoon, ladies and gentlemen. Welcome to the 8th International Conference and Exhibition on Indonesian Medical Education and Research Institute, Connecting Data and Genomics to Human Diseases and Medical Education. I'd like to introduce myself. My name is Anyalir as the Masters of Ceremony for today's event. First of all, I'd like to greet all participants attending through Zoom as well as Medicine FKUI YouTube channel. And before we proceed, I'd like to address several safety induction rules. First, the event will be held online and participants can join remotely from their homes. Please use comfortable and appropriate attire. Please pay attention to the distance between you and the PC, laptop, or mobile device that you are using. And please pay attention to the ergonomic aspects related to sitting position throughout the event. We also encourage you to do stretching every 1 hour. And please pay attention as well to the electrical hazards, especially for cable chargers or switch around you. Please obey COVID-19 health protocols where relevant. And if you experience any symptoms related to COVID-19, please visit any health facility closest to you. And also, please ensure that you have adequate internet quota to participate in this event. So I will read through today's event rundown. So today's event will be held online, and we will have opening remarks as well as the first keynote lecture. And tomorrow, for the event tomorrow, it will be held in person on the third floor of Auditorium IMERI FKUI with the second keynote lecture followed by parallel symposia as well as oral and poster presentations. I'd like to notify you that the registration for tomorrow's event is still open, so make sure that you have secured your spot to attend tomorrow's event. Next, we will sing our national anthem, Indonesia Raya. And to our audience, please be in an appropriate sitting position before we start. Next, we will hear the welcoming remarks from Dr. Adisti Dwijayanti, Master of Biomedicine, as the conference chair of the 8 Eyes on IMERI.
Thank you, Dr. Anjelir Putri. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, good afternoon. Honorable Dean of Faculty of Medicine Universitas Indonesia, Professor Dr. Arifah Rialsam, Vice Dean Professor Duyana and Dr. Anis, Executive Secretary of Faculty of Medicine, Dr. Yuli, Managers and Coordinators of Faculty of Medicine Universitas Indonesia, Respected Director of IMERI, Professor Badrul Hegar, Vice Director of IMERI, Professor Budi Wiweko and Professor Dianta, Executive Secretary of IMERI, Dr. Trinavita, representatives of Cipto Mangunkusumo Hospital and all hospitals of Universitas Indonesia Academic Health System, representatives of Health Sciences Cluster Universitas Indonesia, Head of Department of Faculty of Medicine Universitas Indonesia, Head and members of Cluster IMERI, Research Challenge PIC IMERI, Faculty of Medicine Universitas Indonesia, Board of Professors, Academic Senate, Head of UKK Pusbangki, LMK, and Lab Terpadu, invited speakers, moderators, and free paper judges, distinguished guests, participants, lecturers, and students. I, with Dr. Tommy as the Conference Vice Chair on behalf of the organizing committee, welcome you all to the 8th Annual International Conference and Exhibition, Indonesian Medical Education and Research Institute, 8 Eyes on IMERI. This year's theme is Connecting Data and Genomics to Human Diseases and Medical Education. We bring up IMERI research projects which focus on growing up healthy, growing old healthy, emerging and re-emerging infections in the Indonesian archipelago, vector-borne infections in a changing tropical climate, technology-enhanced learning, interprofessional education, and faculty development and professionalism. We hope this event will lead to creativity in answering important biological and biomedical questions as the basis for making evidence-based decisions to advance research and improve the management of human diseases. Professors, seniors, colleagues, and students, I would like to appreciate the knowledge from our keynote speakers. Today we will have Professor Beben Benyamin and Dr. Anura Shankar, and tomorrow we will have Professor Paul Turner and Assistant Professor Hanani. I also like to thank our invited speaker and all of the free paper presenter to share their research at this 8 Eyes on IMERI. I am proud to announce that this year, Eyes on IMERI conference and exhibition involves speakers and participants from other countries, such as United States, Australia, Malaysia, Pakistan, Nigeria, and Poland. I again thank all of the speakers, moderators, judges, and participants for accepting our invitation. We also thank IMERI clusters for holding the workshops during this event. Thank you all for your participation. Lastly, I would like to thank our sponsors for your support, even though on short notice. Thank you for Indonesian Hydration Working Group, PT Nestle Indonesia, PT Nutricia Indonesia Sejahtera, PT Mandaya Sehat Utama, PT Novel Pharmaceutical Laboratories, PT Vita Biotics Utama, Wira Labs and Gencraft Labs, PT Pure Earth Indonesia, Prodia Widya Husada, Medimedi, and Wacom. Distinguished guests and participants, today Indonesia also commemorates our Heroes' Day. Like the heroes struggled to gain our independence, let us also keep the spirit to improve our research for Indonesian welfare, especially for health. I am sure that you all will feel enriched with knowledge after completion of this event and can build collaboration also between researchers. I welcome you all once again to this conference and hope that you all will have a great time ahead. See you all in person tomorrow at IMERI Jakarta. Thank you. I hope to see you again in Eyes on IMERI next year. Please enjoy today's symposium. Thank you.
Thank you, Dr. Adisti, for the welcoming speech. Next, we will welcome Professor Dr. Badriul Hagar, Pediatric Consultant, PhD, as the Director of IMERI.
Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. The Honorable Dean of Faculty Medicine, Universitas Indonesia, Vice Dean of Faculty Medicine, Universitas Indonesia, and also Secretary and Manager of Dekanat, Faculty Medicine, Universitas Indonesia, Board of Director IMERI FKUI, the Honorable Speakers, Moderators, Facilitators, and Judges, the Head and all the team of Cluster, Core Facility, and Unit IMERI FKUI, and of course, researchers and all participants. Thank you very much for joining the 8 Eyes on IMERI 2023. The current increase in genomic information certainly cannot be separated from the result of higher level experiments and also the centralization of genomic information. By having those information, data on network and gene regulations also be more easily accessible. Linking genomic to data human disease is a major challenge in the field of medical research and also medical education. We are sure that currently many scientists and researchers are interested in this field, and there are even quite a few of us want to develop a genomics center. Of course, we have to realize that genomic science is not as simple as we imagine. A part from requiring very expensive equipment and unit costs, interpreting the data produced also required the support of specific knowledge and experience, so that the result of the analysis can provide an adequate information. And this is also inseparable from ethics. Therefore, the 8th Eyes on IMERI 2023 raised this issue as a discussion topic for the participants so that we can share our knowledge and experience. We always realize that no one person or institution can solve the problem by themselves. We always need professional networking and collaboration. Hopefully, Eyes on IMERI 2023 can be a means for us to build and develop networking and collaboration. We also see quite a lot of young researchers participating in Eyes on IMERI 2023. Of course, this is an appreciation for us. We hope Eyes on IMERI can be part of their journey in developing their talents to become a mature researchers. Okay, so please enjoy the conference, take the benefits from this event. Thank you very much for joining. Wassalamualaikum warahmatullahi wabarakatuh.
Salam.
Thank you, Prof. Badrul Hagar. Next, please welcome the opening speech from Professor Dr. Arif Haryal Syam, Internal Medicine Consultant, MMB, as the Dean of Faculty of Medicine, Universitas Indonesia.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Profesor Badrul Hagar, Director of Indonesian Medical Education Research Institute, Faculty of Medicine, Universitas Indonesia. Profesor Budi Weko as a Vice Director of Medical Science and Innovations, IMERI. Profesor Dianta Sumantri, Vice Director Medical Education, IMERI. Dr. Trinovita, Executive Secretary of Indonesian Medical Education Research Institute. Representative Director from Affiliate Hospital Academic Health System, Universitas Indonesia. Representative from Faculty of Medicine, Universitas Indonesia Department. Representative of the head of Health Sciences Cluster, all head and members of IMERI, Faculty of Medicine, Universitas Indonesia Cluster, moderators, speakers of the 8th Eyes on IMERI, committed members, and all attending participants. Good morning. On behalf of Faculty of Medicine, Universitas Indonesia, I want to welcome to all of you participants of 8th Eyes on IMERI. It is an excellent opportunity for us to gather in this special event to share and update our knowledge. This event has been held annually by Indonesia's Medical Education and Research Institute, Faculty of Medicine, Universitas Indonesia. This year will highlight the main theme, connecting data and genomics to human disease and medical education. In the era marked by extraordinary advances in data science and genomics, the potential for transformation in medicine and education is unprecedented. As there are many interesting topics brought by the expert, I hope that every participant could get a lot of benefits, not only for the doctors, but also for our patients in the future. Few days before, we have started this event with workshops that have been held since November 1st. Other than that, there is a symposium tomorrow, and then this event, there's also competitions for the scientific poster and article manuscript with oral presentations. Lastly, I would like to express my highest appreciation for all the committee members who have successfully prepared this event. For all the speakers, instructors, and participants, I also want to say my utmost thank you for your willingness to share and update our knowledge about this prestigious workshop and symposium. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Ari, for the opening speech. Next, before we proceed to our first lecture, I would like to notify that participants can submit their questions through the Q&A column below or raise your hand to ask a question directly. And let's proceed to our first keynote lecture, which is Growing Up Healthy, the Role of Genomic Dataset in Healthcare. This lecture will be moderated by Professor Dr. Aryono Hendarto, Pediatric Consultant, who is a professor and consultant in pediatric nutrition at Faculty of Medicine, Universitas Indonesia, and Cipto Mangunkusumo Hospital. Professor Aryono finished his medical doctor degree and residency program at FKUI. He also underwent fellowship in pediatric nutrition at Emma Children's Hospital in Amsterdam, Netherlands. He also obtained his consultancy as well as PhD degree at Faculty of Medicine, Universitas Indonesia. I'd like to welcome Prof. Aryono to moderate this lecture. To Professor Aryono, the floor is yours.
Thank you, Dr. Putri, for the kind introductions. Dear professors, seniors, and colleagues, first of all, I want to say thank you to the director of the IMERI and also the conference chair. Allow me to share this important and interesting keynote lectures. Before we start, allow me to deliver greeting to all my Indonesian friends, colleagues. Since today is 10 November, then happy National Heroes Day. As has been pointed by the director of IMERI, bringing genomic data into the field of healthcare, health study, and also health preventions and treatment is a big or huge challenge. That's why on the IMERI this year, we raised the theme of growing up healthy, the role of genomic data set in healthcare. And to discuss this theme, we are fortunate to have two distinguished speakers who in the next 1 hour are willing to share their knowledge and experience, of course, in the field of genomic. Allow me to introduce our first speaker, which is Professor Benjamin. Professor Benjamin graduated from the Institute Ferdinand Bogor, Indonesia in the year of 2000 for his bachelor, and then followed by the graduated from the University of Sydney, Australia for his Master of Agriculture 2 years later. And in the year of 2007, Professor Benjamin graduated his PhD program from the University of Edinburgh, UK. And between the year of 2007 and 2011, Professor Benjamin did a postdoc activity in the field of genetic epidemiology group in IMERI Bergover Medical Research Institute. Professor Benjamin will deliver a talk entitled Genomic Approach in Studying Polygenic Disease. Without further ado, I invite Professor Benjamin. The time is yours, Professor Benjamin.
Thank you very much. Good afternoon, selamat siang, everyone. First, I would like to thank Professor Aryono for the introduction. Also, thanks Professor Badriul Hagar, the director of IMERI, who invited me to this excellent conference. I'm honored to be here. And then also, I also would like to thank Professor Ari, the Dean of the Faculty of Medicine. And then last but not least, thank you also my collaborator at IMERI, Dr. Yulia, who is kind of long collaborator with us here at UniSA. And then Dr. Yulia and one of her student will be coming to our lab next week. In fact, next week, yeah. So we will collaborate on some of our work with the Indonesian sample. So I would like to share my screen. Okay, so can anyone see my screen? Okay. Yeah.
Okay.
Okay, so the title of my talk is related to complex disease, and then how the analysis of the genomic analysis of this complex disease rely on the kind of the theory of polygenic, where the disease was influenced by lots of gene, which has kind of a minor effect as opposed to the Mendelian disease. So this is what I mean is that from genetic perspective, disease can be categorized into two categories. The first one is what we call as a Mendelian disease, where a single mutation in this gene affecting the disease, and then so this mutation is necessary for disease to develop, but also it's influenced by other gene, but their effect is quite small. Okay, so it means that and then the effect of environment is also quite small. You can see here. And then disease that we know that are categorized as Mendelian disease is, for example, thalassemia, which is quite common in Indonesia, cystic fibrosis, Huntington disease. So we call it sometimes as penyakit genetic, so genetic disease. But from a genetic perspective, all other diseases are influenced by genetic. The difference is that the other disease, which is called complex or polygenic disease, is that it's influenced by a lot of gene, and then each gene has a very small effect. For example, we know that 100 of genetic variation affecting schizophrenia, type 2 diabetes, cardiovascular disease. In fact, for phenotypes such as height, human height, or stature, there are 1,000 of small genetic variant affecting the phenotype. Why is it called complex? Because it's also influenced by the environment, and then also the interaction between gene and environment. So why it is called complex. In the past, just a little bit of history, we know that the method to identify gene and also to understand the genetic of disease has been developed throughout the years. For example, in the early 80s, we know that the twins and family studies have been used to understand how much genetic contribute to disease. From that, we know that from our study, we know that almost every trait or disease that measure in human has a genetic component. Okay, so the difference is like by how much. For example, we know that height, 80% of the difference between individual due to the genetic differences, schizophrenia similarly, and then cardiovascular about 40 to 50% of the difference between individual susceptibility to cardiovascular disease, for example, influenced by genetic. Linkage studies in 90s has been successful on identification of gene affecting Mendelian disease mostly, because it is easy to identify gene affecting Mendelian disease. You can trace the linkage between genetic marker and the pattern of inheritance between a family member. But this method has not been successful for complex disease, because we know that the effect of each gene is very small. Candidate gene study as well has been was successful for Mendelian disease, but not successful for complex disease. A lot of false result with no replication. So there was the idea of genome-wide association study. So instead of focusing on single genetic variant, we're now focusing on the whole genome to see whether there is any genetic variation associated with disease. And then sequencing study, exome studies also, it's ongoing. So, and the sample size is increasing as well. So just a little bit of method description about genome-wide association study. So this is the MIND method at the moment for human genetic. And then this is also the method that is being used to analyze some sample in Indonesia with Dr. Yulia. The idea is that, let's say for a disease, we collect samples, so thousands of individuals with diabetes, for example, compared to individual without diabetes or the healthy individual. So it's case control study. There are a lot of different design, but this is one of them. And then we collect all the clinical information from this individual, and then also we collect genetic data using genome-wide SNP chip. And then what we do is basically comparing, is there any differences in frequency across like million of genetic variant between people who has disease compared to people who does not have disease. So this is an example for GWAS that we did for motor neuron disease, for example. Although a number of gene has been identified before, so that's the blue one here, by combining data between the Asian sample and then also a European sample, will be able to identify like kind of novel gene that has not been found before. So basically, for some of you who are not familiar with GWAS, this is how you read this graph. Basically, we have a chromosome from 1 to 22, that's the autosome. And then on the y-axis, we have minus log p-value. So it's basically, this is the p-value of the association, but you take the minus log. So it means that it's, for example, the log minus log 10 p-value of 10 is basically 10 to the minus of 10 p-value. Yeah, so that's it's very significant. The reason why we have this type of threshold, like 5 to 10 to minus 8, is that because we did a lot of testing, million of testing, so we want to avoid multiple testing correction rather than using the standard p-value of 0.05. Yeah, so we use p-value of this rather than 0.05. So from this gene, for example, we can see there are a lot of genetic variation within this GPX3 and IP1, and then this SNP is the most significant one. Okay, so the GWAS has been increasing for the last 15 years or so. You can see that There are 3 different lines here. So the blue one is the number of publication has been increasing here. So there are a lot, 100 for more than 600 publication. I think probably now it's much more than that. And then average number of genetic variant that has been identified per papers is around 40, for example, and then average sample size in the order of 100 to 10 to 100 of 1,000. In fact, the largest one for height, for example, it's include the sample size of 5 million of individual. So this is you can't get that sample size unless you are doing collaboration with other researcher in the field. So it's basically probably each of the center or lab only contribute to 1,000 individual, but because you collaborate with 100 of other lab, then you can get the big sample size. Some of the challenges that I quite frequently mention about the challenge here is that most of the population or sample used for genome-wide association study are European sample. For example, here that about 80%, so the red here, of GWAS sample are European. It's only like 20% or other population, for example, from African, ASEAN, and Latino. It's only less than 20%. Why is it important to study in other population? Is because we know that from population genetic that the allele frequency of for the kind of any genetic variant can be different. For example, lactose intolerant. I think I noticed that Professor Badriul Hagar, one of the studies on the lactose intolerant prevalence in Indonesia. So we know that it's very high. Lactose intolerant. So lactose intolerant is that when you drink milk, you might got diarrhea and bloating and so on. And then it's very high frequency, including myself as well. It's lactose intolerant. And then one of the main reason it's because of the mutation in LCT gene, which has high frequency in Asian population, including Indonesia, but it's very low frequency in European population, for example. And then the other one, the strength of the association can be different between population. In this example is MHC locus for schizophrenia, which can be different effect size. Yeah. And then we know that Indonesia and other Southeast Asian population, home to 500 million people, are not well represented in this genomic revolution at the moment. I think notable exception is probably the involvement of researcher from Singapore, where they do quite a lot of genomic analysis. I think this is one of the best known example that genetic differences or frequency or genetic frequency can have an effect on drug response. You might have already know that the carbamazepine is one of the drug to treat epilepsy, but the response can be different between people depending on the genotype of that individual. So this HLA-B1502 is almost absent in the European population, but it's quite common in ASEAN population. So that's individual who has that mutation and given the drug of carbamazepine might develop Stevens-Johnson syndrome, which can be a serious complication. This is an example of the work that we did is on the motor neuron disease or amyotrophic lateral sclerosis that I mentioned earlier. So basically we did analysis to combine data between the European and the Chinese data, and then we able to identify a new gene that affecting motor neuron disease. So another thing that I collaborate with other researchers, including this is collaboration with Professor Hong Lee and then our student Momin. So basically, Momin developed a method to estimate correlation between disease, but using data from different ancestry group, for example, between data from European and ASEAN population. So most of the method was developed only for a single population, and then they might create bias in the estimate, and then Momin able to develop new method that can be unbiased given the cross ancestry genetic difference between the two samples. So the end point of the most of the research in genomics is that we want to go to what we call it as precision or personalized medicine. Okay, so all of the research that we did, kind of the goal is to be able to do this precision or personalized medicine thing. So nowadays, I think that if a patient visit clinic, they mostly are treated similarly. So this is kind of average patient. So for example, correct me if I'm wrong, for example, people presented with high cholesterol after kind of behavior, diet, and all other intervention doesn't work, probably might be given a drug to lower the cholesterol level. But I think for most patients, probably that improve the cholesterol level, so that's decrease the cholesterol. But for some patients, it doesn't provide any benefit at all. And then, in fact, for probably small minority, it might develop adverse side effect, such as muscle pain, probably, for example, for drug to lower the cholesterol level. So I think the goal or the idea is that can we use genome, environment, and then also other clinical data to be able to differentiate which individual might be able to respond well to a particular treatment or medication. So it's mean that we only given statin, for example, only for this group of individual who we know that they will not have side effect, and then the patient can improve. And then we probably prescribe other medicine or other treatment for people who might not have benefit from that particular medication. I think that's the goal, the idea. So how people do that? One of the things that we have probably heard a lot is about the calculating a polygenic risk score. I think in Indonesia, when I visit Surabaya last year at one of the Indonesian Society of Human Genetic Conference, there are a couple of company, pharmaceutical company that provide service on calculating this polygenic risk score to individual. So what is polygenic risk score? Is basically you got the result from genome-wide association study that an example here that you have, for example, you have identified 4 genetic variation, SNP1, SNP2, SNP3, SNP4 that affecting cholesterol level. Yeah. So SNP1, even individual, so for A allele, so increase the cholesterol level by 1.5 unit. Whatever the unit is, if they have a C allele, decrease the cholesterol by -0.5. You have T allele for this SNP increase by 2. If you have A allele for this genetic marker, decrease by 1.5. And then using that information, we genotype. Okay, so let's say 4 individual here. We got the DNA, and then we use the genotyping chip, and then got the information that the individual 1 for this SNP have a genotype of 80, because we know that each marker or gene has 2 allele. Yeah, it's like that 2 allele. So 80, we know that A is 1.5. So and then this individual has 1A, so you get 1.5 here. and then C here minus 0.5, and this individual have 1 C, so minus 0.5, and then T is 2, and then this individual has 2 allele of T, and then we know that each T is 2, so 2 times 2, you get 4, and then this individual is CC. We know that this individual does not have A, so it's 0. So we just sum them up. So for all individual, and then draw the distribution. And then you can see that individual A here compared to the distribution is among the highest risk because it's on the end of the distribution. And then this individual 4, which has a score -4, is the lowest risk of high cholesterol compared to the population. So it means that we might be able to identify individuals who are likely to better respond to treatment. Yeah, so that's the idea of polygenic risk score. Be able to identify of their genetic risk independent of clinical risk compared to the population. So this is some work by Restu. This is one of our students from Aikman who did a PhD with us while we are at UQ. So Restu did polygenic risk score analysis for motor neuron disease and then compare the prediction accuracy between different methods, also between different kind of combination with other phenotype. So I'm not going to discuss in more detail here. It's just like to show you some of the application of polygenic risk score. The other application of polygenic risk score that we did here at the UniSA is the work by Stephanie Byrne. Is that so we know that I think from a lot of study that improving lifestyle can improve reduce the risk of developing cancers. Lifestyle such as a good diet, exercise, and also whether they smoke or drink alcohol. You can see here that lifestyle, good lifestyle. Okay, so if individual has a score good in their lifestyle, the risk of developing a cancer decrease. So you can see the hazard ratio is smaller than 1, except for prostate cancer, melanoma, non-Hodgkin lymphoma, ovarian, and lymphocyte leukemia. So it means that if people adhere to lifestyle, good lifestyle, then they reduce the risk of developing cancer. And then also we calculate the polygenic risk score. Okay, so based on the genomic information, for individual who has high genetic risk score, so they increase the risk of developing cancer. And then when we combine these two, and then the overall conclusion from our paper is that the individual, although they have high genetic risk score, for most of the cancer, good lifestyle might offset the genetic risk. Another challenge with PRS as well is that the prediction between population is not great. So if you predict between European sample to another European sample, the prediction accuracy is very good, it's close to 1. But if we predict from European into admixed American or South Asian or East Asian, the prediction down to only like, this is an example that the prediction accuracy across different group decrease in terms of the prediction accuracy. Another example is that this is work by Momin again at our center with the supervision of Professor Lee, also showing that the genetic cross ancestry genetic data can be used to do prediction as long as we use the appropriate method, such as the one that Momin developed, because the other method might produce bias. So this is an application of the previous method on the genomic prediction that I mentioned before. So in summary, genome-wide association study is the main method to identify a genetic variant associated with disease, a complex disease, and then we know that 1,000 of genetic variant has been associated with 100 of disease in human. Challenge is that most study are European ancestry using European ancestry sample, and then the transferability up to other population is currently being investigated. And then the genomic prediction, or as part of the precision health or personalized medicine, we might be able to use genomic information to be able to predict individual susceptibility to disease. But this is also still under a kind of heavy development. Yeah, so it's not there yet, but the result so far is quite promising. So we are here at the Australian Center for Precision Health, so working on population health, genomic, and also translation within the University of Australia. And this is our place of work here at Summary, and then this is the main hospital. These are the two research center at University Adelaide and University of South Australia, which going to merge starting in 2 years. So thank you very much for your attention. I'm happy to take any question. Thank you.
Thank you, Professor Benjamin, for your interesting presentations. May I inform you that the discussion will be held after the next speaker finish the presentation. So
Okay.
please stay with us.
Thank you.
Yeah. Dear colleagues, our next speaker will be Dr. Anurag Shankar. I believe that for you who are working in the area of nutrition has been recognized well who Dr. Shankar is, because I think Dr. Shankar regularly comes or visits our faculty every year, and you can see Dr. Shankar education and training curriculum vitae and also the professional experience. And currently, Dr. Shankar is a senior lead investigator for community health and in the University of Oxford, and also honorary visiting research fellow in this also in the University of Oxford, UK, and also in the Ekman Oxford Clinical Research Unit, Jakarta, Indonesia, since approximately 4 years ago. Without further ado, and to make it short, I will invite Dr. Anurag Shankar, who will deliver a talk entitled Genomic for All for the first 1,000 days. Time is yours, Dr. Shankar.
Okay, yeah, great. Thank you so much. It's good to be here, and hope you can hear me all right. If not, just raise your hand. Yeah, it's very great to be able to follow on the previous talk by Dr. Beben, because I think that really helps to highlight many of the things that I'm going to talk about today. So I just want to go over some of the applications of genomics to the first 1,000 days of life, which is essentially the pregnancy and the first 2 years, because this is a really critical part of the life cycle. And let me see here. Here we go. So what can we really do with genomics, just sort of in general? So, you know, as highlighted, certainly there's a lot of genomics work that's been done. One of the key things is the availability, really, of genomic services due to the reduction in cost quite tremendously over the last 20 years. You know, as you can see here, the cost per sequencing has dropped, you know, more than 10,000-fold, and continues to go down. And during SARS-CoV-2, what we saw globally is really a lot more proliferation of use of genomics, you know, for sequencing of SARS-CoV-2, for molecular diagnostics, and so forth. So right now, there's really a groundswell around genomics and what it could be applied to. And we've seen that happen in Indonesia as well, sort of increased in the number of organizations that are active in genomics in Indonesia. And so here's just this sort of overall diagram, just improving what the potential is. And the speaker before me did a fantastic job of, highlighting that. And the key here, I think, is that, being able to, oops, did I lose you? I think I'm frozen here. Uh-oh. Hello. I'm frozen. Let me stop there. Let me see, I have a problem.
I think we lost Dr. Shankar.
I think the connection is bad. Disconnected, I
Yes.
think.
Oh, you still with us, Dr. Shankar? Dr. Putri, can you able to contact Dr. Shankar?
We'll try.
Hello. I think, sorry, I'm back.
Yes.
Sorry, I had an internet failure here at the hotel. Let me restart here. Apologies for that. Let's see here if I can find the share. Hold on a second. Give me a second to relaunch the presentation. Okay, here we go. Let's see here, sharing. Okay, am I resharing now? Can you see that?
Yeah.
Okay, great. Okay, let's see. Let me skip forward here. Let me just skip forward from some of these. So this is, let me just start with this, is that, this is this idea of the translation of genomics to a life cycle framework. This is what we want to look at here. So you can see in pregnancy, so currently genomic services really are about detecting genomic anomalies that might be important for the parents to know of. So it's non-invasive pregnancy testing, sometimes through amniocentesis also. And then as you go through the life cycle, there are a few other applications of genomics for screening, or if the person is ill in some way, and certainly when we get to the elderly also. And Indonesia has certainly been a leader in sort of, pushing forward into some of these areas of genomics, and particularly Indonesia is pursuing precision medicine. And this is really focusing on understanding what are the risks, genetic risks, and treatments that can be done for persons who are already ill in some way, and not so much for preventive or promotive care. And so I want to introduce this idea, which is really about public health genomics. And public health genomics sort of is taking this idea from precision public health and saying, well, can we actually create a genomics for all type of initiative where essentially a large proportion of the population, when they're going through a particular transition in the life cycle, can actually receive genomic services for preventive and promotive care. So not necessarily for being restricted for treatment itself. So here we see this definition essentially where we can, a definition of precision public health, and certainly as it would apply to genomics. So just to go through a use case of this really in the first 1,000 days, as I said, it's a promising approach to improve maternal health and population health. So this first 1,000 days refers to, of course, the pregnancy in the first 2 years of life. And a lot of information goes into making this sort of a precision public health practice. You can see, of course, genomics would be there, but many of these other bits of information, epidemiology, biostats, basic health services, understanding social and behavioral science aspects of the individual. So we've made advances in being able to capture a lot of this information using digital health approaches. So it'd be interesting to be able to further enhance the heterogeneity that could be captured to give better prediction of outcomes, and particularly then engage in preventive and promotive care. So this is what we might envision that could happen, in fact, essentially applying pharmacogenomics, the nutrigenomics, calculating polygenic risk scores right from the beginning during pregnancy itself, and for the child in early infancy, understanding what the various polygenic risk scores that might exist there, and how the care plan for the pregnancy or the child could be changed at that time to optimize the outcome. So this is about, as I said, genomics for preventive and promotive care. So in Indonesia, this challenge for maternal and the newborn health certainly persists. Neonatal mortality, infant mortality, maternal deaths, and so forth still remain high. We all know that, of course, stunting is a continual priority, of the country. So again, is there something new that can be brought to bear on this that would help to accelerate reductions in maternal mortality, neonatal deaths, and perhaps stunting reduction? So I wanted to introduce to you this idea of creation of a center of excellence for public health genomics, because it's not just about the genomic part itself, but also about what an organization can do to be active in the community. So there's this organization who's engaged on this path about integrating genomics into public health. So it's the Summit Institute for Development in Eastern Indonesia in NTB province. So they're looking to see how actually you can deliver maternal care by integrating genomics into that. And the starting point for this actually was a study done long time ago, more than 20 years ago, where the Summit Institute actually did a randomized controlled trial of multiple micronutrient supplementation in pregnancy. And there's a large-scale randomized trial that enrolled around 31,000 pregnant women, observing that multiple micronutrient supplementation in pregnancy reduced death in children about 18%, and about 38% reduction in the death in those children if the mother had been anemic, but she received this MMS. So it shows what the potential of this is. Incidentally, it had a greater impact on reducing the death in girl babies compared to boy babies. So again, suggesting that there is a genomic component, right, genetic component that is helping to basically as part of the pathway on this effect. So rate is the issue just from a nutritional standpoint. The genetic polymorphisms for different nutritional components could affect the pregnancy outcome. So it's known there are these genetic heterogeneities in metabolism of folic acid, vitamin B3, niacin, as I mentioned, vitamin A, vitamin B6, etc. So all of these, in fact, if you were able to sequence these and then understand what the effects might actually be in those persons who had different genetic polymorphisms affecting the nutritional metabolism, you could actually adjust what their nutrient intake would be during pregnancy to help even enhance further a change in their care plan related to dietary intake, and also be able to understand what their susceptibility might be to different infectious diseases during the pregnancy itself, and maybe specific preventive and promotive care that would be useful during pregnancy. So this is sort of the flow chart that we would suggest that essentially a pregnant woman enrolls. She has an nasopharyngeal swab taken, a venous blood sample taken, and this would all be part of the routine normal care package that the woman would receive. Then she would get this genomic assessment for detection of polygenic risk scores for hypertension, diabetes, anemia, intrauterine and growth restriction, many different characteristics for which we have already identified a panel of around 500 to 600 genes that would be very useful to assess. Once those were sequenced and we're able to develop the polygenic risk score, now you can directly feed that information into the care plan for the pregnant woman herself. And then, powered by this innovation that the Summit Institute has done with respect to application of digital health for the team-based care of a pregnancy, you can actually drive a change in real time in the care plan itself. So this is just wanting to introduce you to this idea of the digital health itself. So the Summit Institute and myself and others were actually the creator of this frontline digital health platform that is now, they're working very, very closely in Indonesia with the Digital Transformation Office to work with the government to create these different apps that enable you to transition from what's called provider-centered care to person-centered care. And again, in this team-based person-centered care, enabling you to provide precision care based not only on behavioral characteristics, socioeconomic status, but also hopefully genomics. So that's sort of the next frontier. So this concept of team-based care, next generation care, was given an award to Summit Institute by the World Health Organization. It's one of the top 10 innovations in primary health care. So there's a lot of momentum, again, in precision care delivery for preventive and promotive care. And again, a lot of interest in creating the digital backbone for this, integrating with, in Indonesia, this new initiative that they've launched called the Satu Sehat, which is the one data system, information system. So again, bringing all this different information together from the clinical side, biomedical risk factors, including genomics, behavioral risk factors, et cetera, is part of the normal care that is being delivered. So it means that with this kind of process, you can create this continuum of care really across the hospital, the lab, primary healthcare clinic, and the community itself. All the different frontline healthcare workers can be unified across a care plan. So if there are genomic risks there that can be addressed by changes in care, in behavior, in counseling, and so forth, that can be done as a team in a comprehensive way, therefore enabling the reality to be seen that you can actually deliver changes in care in real time based on whatever polygenic risk scores there might be. So, of course, to do this, you need to be able to do this sort of genomic work at low cost, create the assays, and so forth. So I wanted to introduce you in Indonesia, many emergent genomic organizations in Indonesia over the last 3 years, especially. One of them is the lab here called the GSI laboratory that was created actually during the pandemic. It's currently the most high throughput, lowest cost for both molecular diagnostics and sequencing in Indonesia. And the health minister has been very appreciative of the pioneer work from GSI Lab, led to catalyzing actually the creation of the BGSI initiative in Indonesia also. So it means that the practicality of actually providing these genomic services at scale is also there. Now, of course, along with that, you need to have a platform of some sort that could be useful to give you rapid turnaround of genomic information as quickly as possible in a low-cost way. So one option for this, due to the accessibility, is the ONT, or Oxford Nanopore technology, which is relatively low cost. If you have a planned assay, a multiplex sequencing assay, relatively small number of genes, like 500 or 600, certainly on ONT, this would be accessible at low cost. So many places in Indonesia, even within the routine health services, could actually achieve this. So just to finish up here, these are the quick gains that perhaps could be possible for Genomics for All in the first 1,000 days. So maternal and newborn health, reducing mortality, reducing stunting. You saw the person that presented just prior to me, the other potential genes that could be looked at related to, cognitive development, child growth, et cetera, and also enabling us to do infectious disease treatment and surveillance during pregnancy and early childhood. So this integration of genomics into primary healthcare can be done. It is a reality that I think can be achieved at this time, and especially through this integration with digital health. So this is what I would say is Genomics for All is ready to launch in Indonesia, rapid impact as possible. It'd be very exciting to work together, whatever could be done to get this off the ground, see the benefits of this. I think in Indonesia and IMERI could be a global innovator in this space. So thank you so much. I'm going to end there. Appreciate your time.
Thank you very much, Professor Sankan, for your presentation. That's the role of a genomic for the preventions and treatment in the different health facilities setting. Dear colleagues, we have approximately 15 to 20 minutes for discussion with these two interesting topics, and you may directly ask questions to the speaker, but please use the raise hand feature first so we can recognize you. Yes, I see Professor Budi Eko. Please, Professor Eko.
Thank you very much, Prof. Adiono. Thank you very much, Prof. Beben and Prof. Anuraj. Really excellent talk. I really enjoy it. So just I'd like to know what your opinion is regarding the polygenic scoring, the disease that's based on GWAS, as Professor Beben mentioned and explained about it. So we know that actually this is the combination between genetics, lifestyle, and environment. So how precise the polygenic scoring system in predicting one of populations or people to have a risk for suffering from some disease, and then how do we prevent and count on this kind of the result of the GWAS? Thank you.
So is that question to me? Okay, thank you very much, Professor Budi. So that is very interesting question. So polygenic risk score that was developed from the result of genome-wide association study or from sequencing study cannot be used to predict disease by itself. So usually in some of the research that we combine the genetic risk with all other risk factor. For example, the combination with the lifestyle factor, diet, and then all other environmental factor to be able to get a better prediction of disease. And then at the moment it is still in the development, but the one that is quite advanced, I think this is there are two disease that has been quite advanced in terms of the starting to get some of the trial clinical trial about the use of PRS is in cancer and then cardiovascular disease, because that's quite a lot of big studies done in two diseases. Yes, so it is important to include all other risk factor, like traditional risk factor, clinical risk factor, from biomarkers and everything, and then also from lifestyle and all others. So it means that genetic risk factor or polygenic risk score is only one of the kind of risk factor that can be used on top of other risk factor that has already been used before. So it provides additional information, yeah, to make a better prediction. That's one of the use, yeah.
Professor Sankar, do you have any comment on this issue?
No, I would agree with those comments. I think that the critical thing is to be able to launch some activities where we're really putting together the genotype and the phenotype at scale. So that really, and making that as a routine system. So we can certainly launch something like that with information that we know now that would be helpful, the sort of public health genomics in that context. But only when that becomes a routine service can you continually begin to learn and understand, for each population locally, what is actually important. So I think we know what to do. I think we have to start doing that, because that's what's going to be the engine to get all the answers, that we want. It has to be a routine service. It can't just be a few studies here and there, no matter how big those studies are, because things can change, right? The environment is changing all the time. People's behaviors are changing all the time. So we have to have a way of constantly, dynamically, understanding this. So it should be a core part of the public health system. So yeah, that's what I would say.
Thank
you.
Professor Benjamin, following the Professor Budi questions regarding the genomic risk score. So how high or how hard we have to believe about this genomic risk score? Because looking at what happened or what have been done by the US artist Regina Jolie, who did a total mastectomy, because probably she informed by her geneticist that he has a high risk of a breast cancer.
Yeah, so my understanding is that for case of Angelina Jolie was the information is on using a well-known mutation which has big effect, BRC1 and 2 gene. So that is only a single or 2 or 3 genetic mutation in that gene. And then usually for that type of single gene mutation, the predictive ability is very high. So with the polygenic risk score, it means that because each individual genetic risk, each individual genetic variant affect very small. So it means that to be able to have a good prediction, we need to combine 100 or even 1,000 of small genetic variant into a score to be able to predict them. In terms of how high is the accuracy needed before clinical implementation, I think that's probably my understanding of your question. I think it's as Professor Sankar mentioned, it's kind of work in progress, need to be combination with the application in the field, because of so genetic risk, it's not a kind of it depends on the environmental background as well. So it means that it might not be that the genetic risk, the one that identified in European, might have a good predictive ability in Indonesian, where we know that the environmental factor are different as well. So it need to be taken into account all other environmental factor in Indonesia. I think to be able to put in clinic, I think as all other marker or other treatment, a good, solid, randomized clinical trial are important as well, I think, before anything that can be applied into clinic. Yeah.
Thank you, Professor Benjan. For the question will be delivered by Professor Damayanti. Please, Professor Damayanti.
We cannot hear you, I think, Prof. Damayanti.
Yeah, okay. Now you can hear me? Yeah.
Yes,
Yes,
perfect.
thank you. Thank you for your presentation. I am first interested in what I call you usually Pak Beben, yeah? Pak
Yeah.
Beben. I would like to know exactly if you want to do the GWAS, it's mean that you have to know exactly what you want to know now. If you want to do the study, you know exactly what kind of disease, and then you have the data all around this patient. Then you can make something like the prediction factors that involve in this patient. That is mean that we need a big data, isn't it? Yeah, to do this. Yeah. Now,
Yes.
that's now we don't have the big data yet. But how can you make the study now with the data available? That it means that you have to work with the disease that's already known, and then you can see that what is the correlation with the disease. Yeah, that's what I mean. What I would like to know now, because we don't have the big data in Indonesia yet. Yeah, and secondly, I would like to ask Professor Sangkar. You mentioned about the mother, then you I think you talk about nutrigenetic, isn't it? You see the nutrigenetic and you see the risk of how the mother responds to the multi-micronutrient. If you have something, and then you know that there is several kind of the combination that make this response to the micronutrient is different. And then what you expected in the field. You examine every mother, and then you see, oh, if you're like this, and then you should give this kind of treatment. That is already precision medicine 1 by 1. It's not population anymore. Yeah. So this is what you call it population, but actually this is applicable. I think precision medicine is mean individual, that every person is different characteristic of gene. Then you have to approach them with different kind of treatment. This is the principle. Then with this kind of, you want to know about this mother, examine, for example, for stunting, but actually in Indonesia it's clearly because they don't eat animal protein. Then I'm doing the study, and you give the protein, animal protein, that is the stunting will reduce. But there is some, not all reduced, but that's kind that's not reduced with normal treatment. Yeah, then you should look, maybe there is another kind factors that if I'm not, this is what I can get it. Is that what you talk? You mean that our government should look every person and then give different kind of treatment? But I think this is not the population approach. Yeah, this is my comment on your presentation and for Beben presentation. Thank you.
Okay.
Do you have any?
Professor Sangkar, do you want to answer first? I think probably
Sure.
still
Yeah,
pressed, while
sure.
still pressed.
Yeah. Some interesting points raised there. So one is that the main difference between precision medicine and precision public health is that in each case, yes, you're focusing on the individual, but the difference is that in precision public health, you're focusing more on preventive and promotive care, and you're also providing it as a routine service for everyone. Yes, so it is correct that you would need to, in fact, just like, for instance, now, we routinely test all pregnant women for hemoglobin, right? And that shapes a decision about what additional, intervention or therapy, preventive or promotive care that you're going to do. So the same thing would actually apply for many other aspects. So I use the example there, I use the example sort of as the entry point of nutritional supplementation, but in fact, preventive and promotive genomics for pregnancy would include other aspects as well. So for instance, potential susceptibility to infectious diseases. Actually, genomics apply to what current infections that the mom might actually have. So you're getting this, applying genomics to understand what her risk factors are overall, and then in real time, yes, in fact, altering the care plan. And there's many things that can be done. With respect to the stunting and so forth, it's not actually an issue specifically about animal foods. So one of the interesting issues around the world people talk about is, for instance, how dairy consumption, milk consumption is important. But in fact, milk consumption has been shown to increase the risk of bone fractures and to create abnormally taller individuals because of growth hormones in that. So that's why in many countries they have said, don't give cow milk to younger children, in fact. So, and likewise, the association with stunting in Indonesia, it's not actually because of lack of animal food consumption. It's also related to just general lack of dietary diversity. And we see a large proportion of that related to, in fact, the adequate dietary consumption during pregnancy and infections early on in the first 2 years of life. Now, we do know the interventions that can be done for all that. So certainly a big action can be taken to really reduce stunting in Indonesia. So yeah, that's what I would say. That's my, that's my quick response.
Yeah. But that's what you said and everybody. But actually in Indonesia, it's clearly because lack of milk, then we have a lot of stunting in Indonesia.
No, that's not true. That is not
true because I'm in the field. I'm working with this kind of patient. Yeah. And I'm also have the stunting level increased to 8.4% is only for any not milk, but all the protein, animal source protein in the 6 months, and the stunting level, but I calculate everything by name, and that it reduced 8.4% only by eating that there is no new stunting. Yeah, this mean the nutrition status is better compare what they eat before. Yeah, this is the important thing because the best before the 6 months old baby, they don't give them protein because they afraid of the allergy because of the methods. Yeah, this is the real thing what happened in Indonesia. I'm working in 14 regency, and then what is the same thing? Then I'm also can reduce the new stunting because we change the term of the food. They eat the local animal source of food that is not given before. That actually. That's so I think here's what I would that's what I think I would like to say. That is you to see please is in local there's this different kind of a problem that you should look at locally, not as everybody, but only in local. Things.
So certainly, you know what I would suggest, what would be a good idea? Let's do, if we can, let's do another event where we actually go into detail on all these issues, because we have to be very careful about, what the data is, what the information is. I mean, many of us are familiar with the data from Indonesia, and I think you raise a good topic, but I would just caution against this idea that dairy is an important thing to give, but dietary diversification is important. But anyway, let's have another session on this.
Professor Sankar, Professor Damayanti, I know quite well that we are discussing an important issue, but we have only very limited time remaining. So then we still have many questions in the Q&A column. So regarding this issue, Professor Benjamin, do you have a comment, but please make it short.
Yeah. So I think thank you, interesting discussion. So the question about the sample, I think that's true that it requires a good collection of clinical sample. I think the first step that we can do, I think, given the limited resources for a genome-wide association study with limited sample, is to find a disease or trait that you are interested in. And then with the limited sample, good phenotype, and then you can do in silico meta-analysis. I think combining with the other publicly available data, because they publish summary statistic from large consortium, for example, cardiovascular disease, and then they can combine with the Indonesian sample to identify whether there is any additional signal, or whether the European sample can predict well the Indonesian sample. So I think that's what we can do with the small sample, one of them. Yeah.
Thank you, Professor Benjamin.
Oh.
Now we have to go to the question from participant in the Q&A. Please, Professor Benjamin and Professor Sarkar, reply in this short explanation. I will read the first questions. Maybe addressed to Professor Benjamin. Is there any relation between a bottleneck theory and genetic drift theory and polygenic disease?
Yes, there is a relationship between this important population genetic concept. So bottleneck theory is mean that bottleneck is the reduction in the population because of, for example, a migration to island, for example, and then that's create the bottleneck. The population reduce in size, and then that can create a genetic drift where the allele change, and then it might also impact the frequency of genetic risk associated with polygenic disease. So that there is a relationship.
Okay. Thank you. And secondly, from Dr. Ludi, pediatrician, how to prevent the potential misinterpretation or misapplication of genomic data, which leads to the incorrect diagnosis of treatment decisions?
I think probably I can try to answer that one. So I
Okay.
think it is it's an important issue. I mean, ethical concern genomic data. This is it's important related to the security. We know that Indonesia has not been very good with the data security. With the case with the KTP yang bocor, and then all the information. It's very important, I think, to have the data security regarding the genetic, because it can be misused by other. And then also in terms of the potential misinterpretation, I think good training within the analysts and then also healthcare worker, it's important, so they understand how the data was analyzed, how to interpret them, and then how to communicate to patient in terms of diagnosis and treatment. Yeah.
Okay, and further, the question from Dr. Yulia, Prof. Benjamin, I think the second question from Dr. Yulia. Can you read?
Yeah, so this is related to GWAS for Indonesian population. We know that the population allele frequency can be different between population, and then current GWAS chip at the moment is not capturing enough variation in Indonesian population. So whether using whole genome sequencing is good idea. I think that whole genome sequencing is a good idea to capture like variant that are not represented in other population in the chip. Yeah. So and then whole genome sequencing probably it's important, but it can be still quite expensive, I think. Yeah.
Okay, last question for you, Professor Benjamin, from Dr. Rina. She is a ophthalmologist. How important is it to do a clinical trial for PRS before its clinical application?
It is. I think it's very important. It's with all other new treatment, new diagnostic tool. It's a good clinical trial is important before it can be applied into clinic, I think.
We move to a question for Professor Shankar. Professor Shankar, can you able to read the Q&A column? The question from Deviana.
Yeah, some good questions there. So the question from Deviana, I would say, she's raised a very important point that certainly the genomic assessment of pregnancy and intervention would affect the health of the mother and the child. And part of doing that is actually definitely the preparing of frontline health workers for what sort of interpretation of that would be and how to change the care plan in the counseling. So I think that's why this sort of integration of this with the routine healthcare would be very important. So she's raised an important point. The question from Ibudini Fitrianti, great point on the microbiome. Absolutely. So I think there's some very interesting information that's been emerged the last couple of years on the genomics of the interaction between microbiome and the impact on the health of the individual. So being able to look at the genomics itself of the gut bacteria, and also the genomics of the individual at the same time would be extremely useful to go forward. And again, I think we're developing some tools that are relatively low cost that would probably make it available to do that. So that's a very important part of investigate. I see you have some more detailed questions there. I'll try to send you in an email or something, giving you more detailed answers on that.
Yeah,
then on the let's see, most important aspect, provide affordable genomic. I think the most important so Henny has asked this great question. I think the most important thing as far as the affordability is concerned is focusing on those technologies that enable higher throughput, certainly at lower cost, and that are accessible. So if you're talking about whole genome sequencing, for example, a platform such as ONT might not be the best choice. But if you're looking at targeted sequencing to identify polygenic risk scores for things that are known, something like that would be accessible. Likewise, some of the chip technologies, if you have a centralized facility, those might be very economical to do. I would say that as you get into this, the important thing is to start doing it, because that's how you're able to economize it, especially at scale. And so if we delay it, keep delaying it because somehow it's too expensive or we don't know how to do it, we can never get to the point where we're actually innovative and showing there's an impact on this. Yeah, so I think that's what I would say in response to those. Very good questions.
Yes, a question from Clara.
Oh, okay. Okay. So that's related to polygenic risk score that has been offered in Indonesia related to nutrition, for example. How important it is to kind of my opinion on that. So it's as I mentioned before that the polygenic risk score is also depend on the environmental background, and then at the moment most of the studies on this are been done in European. So I think before application to Indonesian, I think it's also critical to have the kind of the analysis done in Indonesian and then see what the outcome. I think it's for me it is probably it's not at the moment, it is not in the clinical stage at the moment. Probably this is more related to kind of recreational genomic. I think that what 23andMe has been offering. So it's not and has, because like any clinical application need to be to all of the stringent mechanism, I think. Yeah.
The last question, Professor Benjamin from Novi.
Yes. Yes, I think
regarding the
yeah, I think it's important. All other omics data, epigenomic, microbiome, nutrition, and it's all like part of the marker or risk factor that are important to be collected in combination with all other risk factor in genomic, epigenomic, microbiome, and everything. I think these are important. Yeah. And then last one from Clara about is that more SNP better? In theory, the more the better, but it also depends on the precision of the effect size. Sometimes more is not better if the results are not from a good. The estimate is not good, for example. Yeah.
Thank you, President Benjamin. I think we have already discussed all the questions.
If I could just comment.
Oh, yes, please, Professor Sankar.
Just a brief comment on this very interesting point that Novi has raised. And one of the, I think, key points there is this issue about the methylation status. And the methylation status, that is very important, because this is something additional information that's really critical around how genomic expression is there, how it can change the phenotype. And some of the platforms such as ONT are very, very easy to assess that. And so I think that's something we should keep in mind in terms of the type of technologies we're able to promote. And then also I think it'd be interesting to explore how we can create more training around precision genomics and genomics for precision public health. And the GSI lab, for instance, has created GSI Academy, where they're specifically focusing on that. But other organizations could also do such things, where they're really focusing on specific training packages for genomics and interpretation. Because again, how do we make this a widely available service that is affordable? So that's what yeah, that's what I would say. My final comments. Thank you.
Yes, thank you, Professor Tangka, for very important last comment. Dear colleagues, my apology. I have to stop the discussion. I believe you still have questions in your mind, but I have to stop because we have exceeded the time allocated for this session, talking about the genetic and its implementation. Always interesting, but it always takes a long time to discuss. So I will thanks very much to our speaker, Professor Benjamin from Australia and Professor Sanka from UK for your willingness to share your knowledge and experience to your Indonesian colleagues, and hope we can discuss these topics again sometimes in the future. Thank you very much, and I also thank you for the participants who are actively involved in this beautiful discussions. And I hand over the time to the MC.
Thank you very much to our speakers, moderator, as well as participants for the insightful talks, as well as the interesting discussions. I'd like to remind the participants to fill the attendance form with the link provided in the chat box below. And before we close the event, I'd like to deliver several announcements for tomorrow's event. So registered participants can attend the 8 Eyes of IMERI on day 2 on Saturday, November 11, 2023, on the 3rd floor of Auditorium IMERI FKUI. And registration can be done through the link provided on the screen, bit.ly/SYM/Eyes on IMERI 8. And only registered participants can get certificate. And also, I'd like to note that certificates will be distributed at the end of the event tomorrow. And tomorrow, we will also announce the 5 best oral presenters, as well as the 5 best poster presenters. Also, we have door prizes of 2 nutrigenomic examination voucher that is worth 8 million rupiah, which will be distributed to the participants with the most likes on their posts by tagging the Instagram of Eyes on IMERI. You can take screenshots for the links and also the announcement. Lastly, we wish to thank the following companies who have supported us, the 8 Eyes on IMERI: Indonesian Hydration Working Group, Nestle, Nutrisha, Novel Pharmaceutical Laboratories, Mandaya Hospital Groups, Vita Biotics, Medi, GeneCraft Labs, Wacom, and Wira Lab. I'd also like to greet once more the more than 200 participants who have joined today's event online. Thank you very much for your enthusiasm, and see you tomorrow on Saturday for Eyes on IMERI in-person event on the 3rd floor of Auditorium IMERI FKUI. Thank you for your participation.
Should we take picture, Dr. Putri?
Yes, sure. Okay. Oh, wait.